Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice.
Welcome to the Mad in America podcast. My name is Justin Karter, and I'm the research news editor for the Mad in America website. You can read our articles there under the research news tab on the front page. And today, I'm very fortunate to be interviewing Awais Aftab, who's a psychiatrist in Cleveland, Ohio, and a clinical assistant professor of psychiatry at Case Western Reserve University. He is a member of the Executive Council of the Association for the Advancement of Philosophy and Psychiatry, and has been actively involved in initiatives to educate psychiatrists and trainees on the intersection of philosophy and psychiatry. He leads the interview series as well, called Conversations in Critical Psychiatry for the Psychiatric Times, which explores critical and philosophical perspectives in psychiatry. And he's engaged with some of the most prominent commentators within and outside the profession who have made meaningful criticisms of the status quo. He is also a member of the Psychiatric Times Advisory Board. Welcome to the Mad in America podcast. It's great to have you here.
Thank you, Justin. I'm pretty happy to be here talking to you.
Thanks. So to get started, we want to learn a little bit about your background and what led you to a career in medicine and psychiatry.
Oh, wow. That's a long time ago. So I think a lot of people might not know that I'm from Pakistan. That's where I was born and grew up and did my medical school as well. Before I went into medical school, I was really interested in philosophy, and I was seriously considering the idea of whether I could pursue that on a professional basis. But philosophy as an academic discipline, especially as a way of making money, was pretty much non-existent. I do have a lot of physicians in my family. My elder sister is actually a physician herself. So there was all this passive exposure that I was getting through my sister, my uncles, my aunts, many of whom are physicians in Pakistan. So, seeing their example, it seemed like a natural choice for me to, be drawn to medicine as well. So I ended up going to med school. And because I was really interested in philosophy and psychology prior to med school, when I started med school, it became pretty clear to me, pretty much from the beginning that the only specialty that really attracted me intensely and strongly was psychiatry. So in my mind, I was pretty set from the beginning of the med school that I was going to be a psychiatrist. It was not an easy decision, though, because at the time I started medical school, there was a lot of stigma, and there actually still is, but there was a lot of stigma in Pakistan surrounding mental health. And this stigma also affected people in the mental health profession, psychiatrists, psychologists, and other. And so there was a general perception at that time that that sort of like good doctors don't go into psychiatry. That if you have sort of like talent, if you're intelligent, that you're going to be drawn to specialties like surgery or one of the branches of medicine. So there was a lot of resistance, from my family and including some of my teachers in medical school who thought like, why are you going for psychiatry? You could do something else. And so it was a process of partly kind of like talking to them, negotiating with them, and explaining to them that I think I'm really passionate about this, and unless people like me go into the field, how will it change?
And you spoke about the stigma in Pakistan around both being a service user of psychiatric services, but also of being a professional in the field as well. What was psychiatric training actually like in Pakistan? How did that cultural difference impact your experience in medical school? Were there any major differences between how the training was there and then once you came to the US and how it's been here?
Culturally speaking, that there are tremendous differences in how I think medicine in general is practiced in Pakistan versus US, and those differences are present in psychiatry as well. I have to say, like, most of my experience of psychiatric training in Pakistan comes as being a medical student. And in Pakistan, medical training loosely follows the British model. In general, I think psychiatry in Pakistan struggles with being really under-resourced. The ratio of psychiatrists to patients is very low. The availability of medications, especially newer medications, at that time was a big problem. And in general, there were a lot of challenges within the system. So, for example, when I started my psychiatric training in US, some of the things that were really prominent to me was how many that there's a legal apparatus that exists here with regards to mental health care, especially when it comes to involuntary or forced psychiatric detention or sort of like pathways such as sort of like describing under what are the situations and what are the circumstances in which someone can be admitted to a psychiatric hospital against their will. What are the circumstances in which you can like petition the court for forced medication. So there is some sort of like a legal apparatus, some sort of a system of rules exists that sets some boundaries and also establishes some accountability in a certain way. Versus in Pakistan, there's literally nothing when it comes to laws relating to mental health care. So there's this sense of chaos in which when you're treating someone and let's say the family is concerned about a patient who might be either going psychotic or might be experiencing episodes of mania or severe depression, there's no clear-cut pathway as to like what is supposed to be done, what's going to be next. It's not like they can call like 911 or the police there and have the patient transported against their will to the emergency room or to the physician. So people end up sort of like responding in very different, sometimes creative ways, and sometimes that involves like deception on part of the families, which sometimes can sort of like cross into the boundary of what we may call unethical. Like it's pretty common there that family members would obtain psychiatric medications and mix it into the food of a person without that person knowing, and so I mean that's not ethically defensible, but I think you can sort of like see it as a consequence of a society that has failed to develop other ways, formal ways of addressing these problems. And another thing is that here, majority of psychiatric prescriptions, like you have to go to a doctor has to prescribe the medication to you. In Pakistan, things are a little bit changing now, but back when I was there, it was essentially you could go to any pharmacy and get any medication you want. So there wasn't that, the psychiatrist was not the gatekeeper of psychiatric medications there. Like anyone could go to any pharmacy and get, and obtain a benzodiazepine or obtain an antidepressant. So even though the number of psychiatrists might be limited, the use of psychiatric medications was still like very common just because, people could get them on their own. There's another sort of like interesting thing that I noticed in terms of patient presentation. So I do think when it comes to depression or anxiety, a lot of people in Pakistan presented with what would be considered a neurasthenia type of presentation, in which they are focusing much more on somatic symptoms such as headache or physical fatigue or weight and digestion issues. So there was this emphasis that to sort of like privileging body problems, physical problems over mental health problems. So people tended to present when they were depressed or anxious in that classic neurasthenia sort of manner. We used to see a lot of conversion disorder cases, far more than I've seen in US. And I think this is partly the fact that the conversion disorder is seen much more in females, and women are, especially they were at that time, but they still are highly oppressed in many ways, within the larger social system. So I think the high rates of conversion disorder that we were seeing there were sort of like a barometer of social oppression. But in that same vein of like how culture and societies can affect presentation. Before I started my psychiatry training in the US, I had spent almost nearly 1 year of psychiatric training in Doha, Qatar, and and things are, Doha, Qatar is very different either from Pakistan or from the US in the way their society is organized. And in Qatar, they have almost what you can call a slave class. You have these laborers that come from various South Asian countries like Pakistan, Nepal, Bangladesh, India, who are generally illiterate, who come to Qatar seeking work, and then they get trapped there for various reasons, and they're working in really horrible conditions. And while I was working there, we were seeing extremely high rates of what is called a brief and reactive psychosis. That is these episodes of brief psychosis that seem to arise in situations of really high stress. And so that was a very common presentation among those laborers in Qatar. And versus in contrast, it's relatively rare to see brief reactive psychosis, just because the society is not oppressive for most of us in the same way as it might be in other countries.
Yeah, and it sounds like your experiences were really rich for thinking about these philosophical questions that come up in psychiatry and psychology as well, as far as the role of culture in the experience of mental distress, as far as issues around coercion and deception in psychiatry. And I'm wondering about how your philosophical training continued to develop during this period of medical school. I know that you produced an excellent blog on the history of modern philosophy while you were in medical school, I believe. So I'm wondering, how did that study of philosophy continue for you? In which ways did it complement your medical training? And in what ways did your medical training challenge some of the philosophical ideas you were reading about?
Thank you. Yeah, I think, as I mentioned, my real love was always, even before I started med school, it was really philosophy. So even though I was in med school, and I think everyone recognizes how busy med school can be, I still was devoting a lot of time to my personal reading of philosophy, and at that time I was doing a lot of reading in history of philosophy, especially history of modern philosophy, from Descartes and onward, and trying to understand the trajectory of philosophical evolution, and trying to sort of like get a better sense of that. So as I was doing all that study, I was sort of like keeping notes. But once I had accumulated a relatively large volume of notes, I realized that with some more effort, I could give them a little bit more form and shape as sort of this book, in a blog form. So it ended up being this blog, or you can sort of like call it like a blog book on the history of modern philosophy from an amateur's perspective. And I think that personal study gave me a pretty solid foundation for further philosophical inquiries and further philosophical areas that I was interested in later on. I initially, when I was doing all of this study in philosophy, I didn't see it as being that relevant to medicine. There was, a bit of a disconnect in my mind. But I think as I progressed, I began to appreciate the ways in which philosophical thinking can inform medicine, but also sort of like the ways in which there are all these hidden conceptual dynamics that are present in way people how make sense of distress, in which people talk about disease categories and the way they approach them. So I began to see this hidden philosophical structure beneath the practice of medicine. And this became much more apparent to me when it came to psychiatry, that because psychiatry is one area where things are relatively more subjective, where there's a much stronger influence of values. And so it's easier to see the influence of some of those philosophical assumptions in how things are practiced. But I don't think that the nature of the underlying philosophical assumptions is that different in rest of medicine. Another big influence in this area happened during my final year of med school. And that's when I became familiar with the work of the famous existential psychotherapist, Irvin Yalom. At that time, I was personally really interested in the existentialist philosophers. So I was kind of exploring the views of Nietzsche at that time, Heidegger, Sartre, Camus. And so sort of like when I discovered Yalom and I started reading him, that was that made a huge impression on me, especially as a medical student. And I love the way Yalom integrated existential thinking into his practice of psychotherapy and psychiatry, the way he made sense of people's distress, the way he made sense of their anxieties. And I really enjoyed that, and I think that, and I'm really glad that I was able to read and appreciate Yalom at such an early stage, because it gave me a much richer appreciation of what psychiatric practice could be like if done in the right fashion. Later on, after med school, but before starting my residency in US. I also read The Divided Self by R.D. Laing, who, as many people would recognize as being one of the so-called anti-psychiatry thinkers or anti-psychiatry philosophers. The Divided Self was his first book. That was before when anyone would have recognized or labeled him as being what we would call anti-psychiatry. But it's a very fascinating book, because R.D. Laing is trying to understand psychosis from the perspective of existentialism. He's trying to make sense of the delusions, the thought disorganization, the paranoia from an existential perspective, and he's desperately trying to see meaning in that. I don't think I was fully convinced by what I read in that. But I think that the sheer force and beauty of that intellectual effort left a deep mark for me.
Yeah, and you mentioned that you started reading works of philosophy that were being applied to clinical practice in different ways. So existentialism from Yalom being applied to psychotherapy primarily, and then R.D. Laing's work taking existentialism and phenomenology and applying it to the lived experience of psychosis and how to engage with it in a way that could be meaningful. But these two camps of sort of a pure philosophy of psychiatry, and then a critical or sort of a applied, engaged application of philosophy in critical psychiatry. How did you come to, after R.D. Laing, explore more of the critical psychiatry and anti-psychiatry movements, and how did that shape your thinking?
When it comes to the, sort of like this relationship between philosophy of psychiatry and versus sort of like, what we now loosely call critical psychiatry, there is a big overlap, but they're also in some ways relatively distinct and somewhat insulated from each other. So I was, for much of my psychiatric training, I was sort of like actively reading literature in philosophy of psychiatry, and I was familiar with the intellectual work of the classic anti-psychiatrists, Thomas Szasz, R.D. Laing, and Michel Foucault. But despite that, despite having sort of like philosophical familiarity with the classic anti-psychiatry thinking, and at least the philosophy of psychiatry literature that I was engaging with wasn't explicitly or wasn't intentionally dealing with what we may now recognize as being critical psychiatry issues. The way we classically think of the critical psychiatry movement is that it has very strong roots in the UK, particularly in the critical psychiatry network, and I think until recently they the influence in America was not that much, particularly if you look at like American journals or most of the academic literature that originates from inside America and that American trainees are more exposed to. So even though there were articles and things related to critical psychiatry that were showing up in British journals and some of the international journals, I wasn't really getting a lot of exposure to that in American journals. And also another thing is that I think a lot of these critical psychiatry debates were happening in a much more prominent fashion online, especially on Twitter, maybe on some of the blogs. So the end result is that my exposure to sort of like this body of views of what we would call critical psychiatry happened pretty late, almost sort of like near the end of my psychiatric training. And I think it was, I would say it was relatively shortly before the book, the edited book, Critical Psychiatry, that was edited by Sandy Steingard, that came out. But before that, I did almost 1 year before the Sandy Steingard's edited volume on critical psychiatry came out. I did end up reading Anatomy of an Epidemic by Robert Whittaker. Now, I don't think like Robert Whittaker, at least in that book, like presents his views as being representative of some sort of like critical psychiatry. But I think, loosely speaking, I think many would place that book within the larger canon of that. And that was reading Anatomy of an Epidemic and engaging with that ideas was quite an experience for me. The book has had a pretty terrible reputation. Most of the people that I had spoken to or people who had mentioned that book before had been pretty superficial and dismissive about that, sort of like calling it sort of like extreme or anti-psychiatry. And so when I decided to read that, I was expecting that this was something I'll kind of like quickly go through, and it's not something that I'll have to like spend a lot of time and energy on. But that actually reading Anatomy of an Epidemic ended up being a very jarring experience, because sort of like I quickly realized that a lot of the arguments and a lot of the data that was presented in the book was not easily dismissed. And the nature of what was being discussed, that is, the possibility that psychotropic medications can worsen outcomes or worsen quality of life, at least in a subset of patients, was one that was particularly unsettling to me. So so I kind of like think back to my sort of like relatively naive days, you can say, when I wasn't exposed to this like larger body of work, and I was thinking that I would just be like I'll quickly be done with it. Versus I read that book, and almost like 2 years later I'm still thinking and trying to address those issues. So I think like that book left a pretty deep impression on me. But it wasn't just because like I accepted the arguments of the book, or I was sort of like immediately convinced that everything that is being said is correct. But I think I could see that a lot of the arguments, at the very least, are worthy of serious engagement, and that this is something that I need to figure out and make sense of. And as I started talking to other psychiatrists, in the community, I realized that a lot of other people had actually, read the book too, and a lot of them were struggling to make sense of these issues in the same way as I was. So, this was a relative surprise to me, because, most of people who have read this book, especially within the psychiatric community, there's a tendency not to talk about these issues, But I think if you talk to them on a personal level, where they might feel free to talk more openly, a lot of them would say that they were unsettled, that the book is not something that they can immediately dismiss, that this is something that they are actively trying to make sense of. So that, I think, that book kind of launched me into a whole new different area of inquiry and study. And then much later on, I think, I would say almost like 7-8 months ago, when I started becoming more active on Twitter, that's when I started getting more exposure to the critical psychiatry folks in the UK, and started reading their stuff.
Yeah, and so it's relatively recent that you were exposed to the philosophy that's going on within the critical psychiatry movement, as well as the other arguments and data being presented. And then you've been leading this series of interviews for Psychiatric Times called Conversations in Critical Psychiatry, interviewing a number of these leading figures, as you said, in both philosophy of psychiatry, but also in critical psychiatry. Can you tell us about how that came about and what your goals were for doing that interview series?
Yeah. So when I started this interview series, and it's been a little over a year now that the series has been ongoing. So at that time, I was kind of like a little bit loosely aware of the existence of critical psychiatry movement, but like I said, it doesn't have that much of a presence in US, at least in that formal sense. So I didn't quite understand sort of like critical psychiatry in the same way as someone from UK, or someone who is really active on Twitter might understand it. So I had a relatively more neutral idea about that term critical psychiatry as sort of like as being representative of sort of like the very diverse ways in which critical thinking and criticisms are being directed at psychiatry. And so I was actively reading that literature, and I felt a weird disconnect, because I was reading these things that felt really sort of like serious, worth engaging with. But at the same time, almost nobody in mainstream psychiatry was talking directly about these issues. There was a tendency to either ignore them, just kind of like being different to them, or to talk about them in informal settings. So that was a little frustrating for me, because I thought that these critical perspectives have something valuable to offer psychiatry, and that psychiatry, in fact, could really benefit by engaging with them, and it can help us, develop our field further in a robust manner. So I wanted to sort of like start some kind of an avenue where we can have a meaningful engagement with these critical ideas, and sort of like where I can get to highlight some of the issues that I think are important for a field. And I think I was lucky that I had a good working relationship with the Psychiatric Times editorial team at that time. And when I pitched that idea to them, and I think initially there was some hesitation, pretty understandably, because like no one really had done anything like that, at least in sort of like mainstream psychiatry. So no one really knew what exact shape this would take and how this would be received. But they decided to take a chance on me, and I think I'm really glad that they did. And I think overall the sort of like the series has done pretty well. So going back to sort of like the reasons why, so one reason was that I wanted to highlight the sorts of criticisms, the sorts of critical perspectives that I think we as a field needed to hear, even though I may not personally agree with all of them, or I may not think that this is something that all psychiatrists should think that way, but I still think it's very important that we hear these things and engage with these things. Secondly, I was still in this project of sort of like learning more and imbibing more knowledge and making sense of this stuff. So I thought this series would present sort of like an excellent opportunity for me to learn more about these critical ideas and perspectives as well. And very importantly, I wanted these engagements to happen in a relatively non-threatening, productive manner, because I think there's this tendency where there's this unhelpful dynamic that develops when criticisms are made, that the criticisms tend to be aggressively presented, and then sort of like the other side, the mainstream psychiatrists sort of like may react with in sort of like in the state of like being totally defensive, and that's not really that sort of like offense defense argument counter argument sort of thing doesn't help learning or a meaningful engagement. I mean, that's good if you want to refute something or if you want to like dismiss something, but it's not conducive for learning. So it was really important to me that these interviews happen in a non-confrontational manner, so that we can, so that the readers can sort of like think about these issues without sort of like without being threatened.
So as you began this Psychiatric Times interview series, you sort of ended up in the middle of two worlds that weren't always speaking to each other in a very productive way. So I'm curious about, I guess, two things. One, what has the response been sort of on either side? How has the mainstream psychiatric community responded to hearing these critical voices in Psychiatric Times? How has the critical psychiatry movement sort of at large responded? And then also, what have you noticed being in that intersection? What have you noticed about that discussion, how it tends to play out online and on Twitter, as you mentioned?
Talking about the response, overall, I have to say, and I was a little taken aback by this as well, overall, it has been very positive. And I was surprised by how well these interviews were received, at least by the people who were reading them, and even by psychiatrists that sort of like, you would think as being thoroughly mainstream, as sort of like, operating with the current mindset. A lot of them actually really found the interviews to be thought-provoking, as sort of like, raising a lot of interesting points. I think a lot of people may simply have ignored these interviews initially in the beginning. So I think initially, I think a large chunk probably didn't really care for these interviews that much. There was, sort of like a relatively, sort of like smaller chunk that sort of like, found these really interviews to be really worthwhile and positive. And then there was a smaller group that sort of like, responded in a little bit more critical manner, sort of like saying, I don't really think this, like, such series focusing on critical ideas is such a good thing. That's not what we need. That's not what the field needs right now. So there was a small amount of backlash, but it was fairly small if you looked at the people who like these interviews, within the psychiatric community. I have to say that the criticisms have not been to the extent that I might have feared. When I started that series. So again, I have to emphasize that I think overall the reaction from the psychiatric community was very positive. And I think, to some extent, that may depend on the way these ideas and arguments were presented. So, for example, the very first interview was with Alan Francis, and I think that that said something about the intentions of the series, because Alan is someone who was essentially part of the psychiatric establishment until about 2000 or so. I mean, he was involved with DSM-3. He was a chairman task for DSM-4. So he was one of the architects of modern psychiatry, as you can sort of like see it. But then as the DSM-5 development process began, and at that time, Alan had pretty much retired from most of his professional psychiatric responsibilities, he started, we started seeing a different side of him. We started sort of like seeing the critical side of him, and he started sort of like, writing much more about philosophy of psychiatry. He started sort of like, writing about the limitations of DSM, the way that DSM is misapplied and misunderstood in sort of like mainstream practice, and what are some of the harmful effects that has had on society at large. But because Alan has that background as being one of the architects of modern DSM, like no one can come out and say that, oh, Alan, he's just anti-psychiatry. Like, that's just an argument that no one can make in any, good faith. So, I think starting off with someone like Alan was symbolic, because it shows that, where sort of like the series is aiming to be like firmly footed within the psychiatric tradition, but it's also sort of like honest, and it sort of like wants to explore these criticisms in a genuine manner, without necessarily sort of like, going to the extreme that people, might consider to be, so-called anti-psychiatry. And then another example you can sort of like have is that when Anne Harrington's book came out last year, a lot of the initial reaction to that book tended to be relatively negative, and that was mostly because early on people hadn't really read the book itself, but they were mostly relying on the various book reviews. When I decided to interview Anne Harrington, I was anticipating that there's probably going to be like more backlash to the interview. But actually, when I think when the interview came out, like Anne Harrington presented herself sort of like in a very balanced, scholarly, thoughtful manner, without any sort of inflammatory comments or anything like that. And and similarly, I think the interview was very well received, even though the same people might have reacted negatively to the general perception about the book. And I think that gave me a very valuable lesson about the importance of context, that it's not just what the arguments are saying. It's not just about the content of the argument, but the context of the argument also matter, and then the perceived intentions of those arguments also matter. And that, I think, if we want psychiatry to engage with these critical views, we have to present them in a context where the mainstream psychiatric community would be able to engage with them. I think since then there have been some interviews that have generated more controversy. I think two interviews in particular, one with Joanna Moncrief, I thought generated a lot of discussion, sort of like on both sides. Some people sort of like felt really strongly that sort of like what Moncrief was saying was wrong, or sort of like or they sort of like they didn't sort of like like the overarching sort of like trajectory of those comments. But at the same time, Moncrief has a large fan following as well, and I think there were a lot of people who really liked that interview. Then the interview with Giovanni Fava, I think was more controversial, because we had touched upon some of the more sensitive issues surrounding psychopharmacology, especially these concerns related to possibility of worsening long-term outcomes in a subset of patients, issues of withdrawal, and then some of the other critical issues surrounding psychopharm. And I did notice that the Giovanni Fava interview definitely generated more critical comments and some more backlash, at least online and on Twitter. So kind of like, I think like talking about sort of like how these conversations happen on Twitter, I'm seeing a similar sort of polarization between sort of like people defending mainstream psychiatry and people criticizing mainstream psychiatry. Is that sort of like you're seeing this exchange, this back and forth between sort of like relatively extreme positions. People get really sort of like aroused and sort of like emotionally engaged in these debates, and sometimes these debates like turn pretty ugly. And and at the same time, sort of like I think the way in which sort of like a philosophical perspective can offer you a little bit of nuance, a little bit of stability in the atheism, new atheism debate, having a little bit of that philosophical sensibility can help you sort of like be grounded in sort of like, in the polarized debates that we're currently seeing on social media when it comes to psychiatry, critical psychiatry as well.
That leads perfectly into what I was hoping to talk about next. You've proposed this idea of conceptual competency as a framework for improving mental health training in psychiatry. And the goal there is to bring some philosophy training to psychiatrists and other mental health professionals. I'm wondering what you think philosophy would add. How would it help trainees coming into the field be part of these conversations that you're talking about between critical perspectives and mainstream views? How would it change practice? And what do you think some of the major conceptual issues are that trainees should be exposed to?
I've been very engaged in efforts to promote philosophy of psychiatry amongst psychiatric trainees, and while I was chief resident at my psychiatry residency program, I developed this sort of like preliminary curriculum for teaching philosophy of psychiatry to psychiatry trainees, and which I implemented at my own program for 2 consecutive years and it was received very well by the residents. And we ended up publishing a report on that in academic psychiatry. And then recently, me and Scott Waterman, we kind of like got together and we wrote this piece for academic psychiatry in which we are arguing for this notion of conceptual competence in psychiatry. And I think, we definitely weren't the first ones to like talk about this. You yourself have written about conceptual competence when it comes to psychiatric diagnosis in the past. But I think when it comes to like, the mainstream psychiatry, we were probably one of the more prominent voices in talking about this. And our basic sort of like notion was that, it's pretty well established now how there are all these implicit conceptual assumptions that are guiding psychiatric perspective, sort of like assumptions related to what a psychiatric disorder is, assumptions related to what the psychiatric classification represents, assumptions related to sort of like the border between normal and disordered. If we recognize that there are all these conceptual assumptions and conceptual ideas that are influencing psychiatric perspective, then why don't we talk about these assumptions and examine them and sort of like engage with them in a more explicit and rigorous manner? Like, why do we sort of like let it stay implicit? So the main sort of like idea is that when we train psychiatrists to recognize the conceptual ideas that are influencing their approach, the conceptual ideas that are dictating and sort of like guiding their practice. And I think it is precisely our neglect of these conceptual ideas that has led to some of the more widespread problems of reification of psychiatric constructs, when we think that these DSM constructs represent some sort of discrete diseases that exist out there, or we sort of like we attribute more reality to these constructs than is warranted, or sort of like or the issue of widespread medicalization. Sort of like how do we draw the boundary of what should fall within the domain of medicine, and how should we sort of like understand the situation? Right now we're sort of like the process of medicalization just kind of like operating through its own logic, and we're seeing this steady expansion in sort of like in the proportion of the population that falls with sort of like under these various constructs. So my main goal, in sort of like in promoting conceptual competence is that, that trainees start asking these questions, that they become more explicit about these hidden philosophical ideas. And I think once that happens, then we can begin to ask like more meaningful questions about, like what to do next, and, how can we change things. If we have more awareness, if we have more understanding, then I think we can engage with these philosophical issues. We can engage with these critical issues in a more productive manner, and we can start making the changes in our practice that need to happen.
There have been other movements in the field of psychiatry recently, such as the movement for multicultural competence and humility, to help train mental health professionals to think about the role of culture in experiences and expressions of distress, and also for structural competence, which is a movement to think about the ways in which institutions, structural discrimination, systemic racism impact clients and patients. So I'm wondering, how does conceptual competence, complement these other movements, and what would it add to those existing movements in the field?
I think the development of cultural competence and structural competence are some of the most promising developments that have happened in medicine and psychiatry at large over the last 10 to 15 years. And I think that these movements are really forcing us to engage with issues of cultural diversity, the way culture affects medical presentations, including psychiatric presentations, and very importantly, to when we're discussing culture, that we don't assume the Western perspective to be the default natural perspective, and so I think sort of like getting away from that dangerous sort of mindset and sort of like looking at culture from sort of like this larger perspective, and being more mindful of the ways in which we can be more respectful and we can be more understanding of the way culture interact with medical and psychiatric problems. And then I think structural competence is doing a really wonderful job in highlighting the ways in which various social systems, the way sort of like the forces of oppression, sort of like whether this is like gender discrimination, racial discrimination, whether this is economic inequality, whether it's extreme poverty, like how are these influencing like medical conditions? How are they influencing their prognosis, and how are they influencing access to treatment? And there's a pretty good body of literature to now show that we need to be more, that physicians and psychiatrists need to be more mindful of the way these social forces operate if we are to provide good care to our people, and that we don't just have to look at the individual patient in front of us, but we also have to think about society at large.
And to take this a little bit further, if a psychiatric trainee or a psychiatrist were to make a study of conceptual competence curriculum, or to utilize the framework, how do you imagine that would change daily practice? And if you were a service user showing up to a psychiatric visit, how might you experience that visit differently if that training had been available?
It's difficult to sort of like say exactly how conceptual competence would change psychiatric practice, primarily because the emphasis is first on recognizing what the hidden assumptions are, and what sort of like the questions are that need answering. The approach of conceptual competence doesn't necessarily provide the answers themselves, because when it comes to philosophical questions, whether these are questions in philosophy of medicine, philosophy of psychiatry, or philosophy of science largely, philosophical questions rarely have clean-cut, settled answers. It's more of a process of dialogue that you have to sort of like, engage with a question. You have to sort of like, think about it, and sort of like, you have to reflect on it. But one thing it does do is that it helps weed out some of the bad answers. Sort of like some of the, there are some approaches to psychiatry that, if you are conceptually competent, you can see that they are, mistaken. So, for example, this reified view of DSM as representing sort of like, discrete disease entities, as if, that these criteria represent some sort of reality that is above and beyond. I think, someone who is conceptually competent is better able to understand the pragmatic nature, or sort of like, of these constructs, are sort of like the functions that these constructs serves. So I think conceptual competence can help psychiatrists be immune to some of the misguided tendencies that we are seeing in current practice. And I think by virtue of being more thoughtful like my hope is that they would be able to engage with patients and with the society at large in a much more healthy fashion. Because right now, what we're seeing, if you look at the public education that is being done with regards to psychiatry, the public is getting a very sort of like biomedical understanding of what a disease is. There was all this talk of chemical imbalance. There still is to some extent, but if you go back 10, 15 years, there was a lot more talk of chemical imbalance, or sort of like there's still talk of disorders being brain diseases, things like that. So the public is getting a certain version of how these things should be understood, but someone who has a better conceptual and philosophical understanding of these issues can easily see that these claims that are being made about brain disease and some of these other things, they're somewhat simplistic, and they might not be helpful, and that a more conceptually healthy understanding of these disease categories, of these disorder categories, is going to be very different. So if they have that sort of like openness, or like this conceptual understanding in their mind, that I think when they're seeing patients, when they're informing patients about diagnosis, when they're educating them, or when they're listening to their concerns, I think my hope is that it would have an influence on that as well, and we would be able to like think more outside the box, and we would be able to listen in a more healthy and sincere manner to some of the long-standing concerns that the consumer, survivor, ex-patient community has had.
Yes, thank you. It sounds like the conceptual competence would lead to, as you're speaking about, a change in the relationship between service users and providers as well, and that there would be, you said, more humility and maybe some more openness, and less a sort of expert who is identifying something that's very easy to identify, and more of a dialogue between parties. Would you say that's accurate?
Exactly. And I think the emphasis on humility is something that is very important to me. In fact, one of the elements of conceptual competence that we outline in our paper is the sort of like the fourth element is conceptual humility. Sort of like this idea that these are really challenging questions, that, there are often competing answers, reasonable people can disagree, and that the best approach we can take is sort of like, be open-minded, be humble about the possibility that what we are thinking may not turn out to be the case, that we could be wrong. And I think that sense of humility can enable us to sort of like have a dialogue in a more open and sincere manner, and also listen to other perspectives. Even if we may not agree with them immediately, at the very least, if we begin to engage with them, to listen to them, to give them the respect and the attention they deserve, I think we would see a very different sort of psychiatry if that happens.
Absolutely. And thank you so much for this interview today. And thanks for joining us here on the Mad in America podcast.
Thank you again.
Thank you for listening to the Mad in America podcast. Visit madinamerica.com for more news, views, and updates.